Thank you very much for the very nice presentation. Questions?
I wanted to know if you had any interference with pacemaker in some patients, because we had one experience where we had to lower the output. I don't know if you have observed that kind of complications.
We noted one time a patient with a very high output, and we have some interaction artifact with the ADL signal. But just for one time, it was very high output.
Any other questions? Maybe I have a question for you regarding the sedation, monitoring of sedation. Can you just elaborate a little bit more on that? How do you actually do that? I mean, I'm just used to steer sedation based on clinical assessment of the patient. So what information does the diaphragmatic EMG give you in addition to that?
It's not very accurate, but it's to the goal when we put the NAVA probe, it's to have a waveform DADI, because very often the patient have a very heavy sedation and we have just a flat line. So our goal is to see a waveform of DADI.
So you're aiming for keep the diaphragm busy?
Yeah.
Or the DADI busy at least, yeah. Any other questions?
So how does the EDI signal look like with unilateral phrenic nerve paresis? Is there anything different in EDI low signal or?
With unilateral paresis?
Yes.
We have a very nice waveform of the ADI. We are very surprised to have a nice signal, and maybe it's a compensation mechanism, but the signal, the IDI max is higher. Often we have a level, it's value, it's 10, and very often when we have a unilateral paresis, it's higher ADI value.
But the curvature is completely normal and it gets back to 0 at the end?
I don't remember that.
Let me just ask you a specific question on the use of or your strategy by patients who have a Fontan circulation, because obviously this is a very specific patient group where the potential heart-lung interactions become very relevant. What is your goal when you apply NAVA for these patients?
For Fontan, usually we use it's a fast track treatment. So very often the patient was very extubated very fast. So sometimes the patient were ventilated with pressure support, and if we have some difficulties because there are an infection, at this point we try another support and we try with NAVA. But for this patient, very often we use a pressure support ventilation, and the extubation is very fast.
Now for the audience who maybe don't know those problems, I mean, these are patients who are completely dependent on their venous return for their cardiac function. There, the oscillations in the intrapleural pressure have a big importance, and therefore, especially the positive pressure ventilation during the pressure support can be very counterproductive. So I was just wondering if you have, by applying NAVA, if you have a way to enhance the
we don't have the use for this patient because we reserve NAVA mode for patient for long-term ventilation or for complication, but it's just for Fontan with some complication.
Okay, thank you very much. I think we move on to the roundtable.